स्क्रीन नहीं आ रही ये अरे hello, good evening all. Welcome to this particular session of 25 most important questions in ENT that are really very important for this upcoming FMG examination. Good evening all. Drastovich, Gabarjova, Namaste. Hello everyone. To all the local languages of the foreign medical graduates that I know, good evening. I hope I am very much audible, live and alive. We people can see each other. Good evening all. I'm good, I'm totally fine. Good evening. Believe me, this session of 25 most important questions will give you goosebumps. You'll enjoy each and every question. You'll enjoy each and every tricks. You'll enjoy each and every methodology, and you'll enjoy this session a lot. Let us be live. Let us answer all the questions positively. I mean, you people are my white coat soldiers, comrades. Good evening. Pranam. Within the next 30 seconds, I'll start with this session. Good evening all. Namaste. I know. Even I was waiting for this particular session. Very beautifully designed 25 most important questions of ENT. Just one disclaimer to all of you. As soon as I start with these 25 questions, whenever you see the question, take your time, 1 minute only. Let us prepare ourselves. Let us brace ourselves for this particular FMG examination. Take 1 minute, solve the question, and we'll discuss. In that discussion part, will take time. But quietly read the question, answer it very positively, and we'll enjoy this particular session. Good evening. Namaste. Good evening all. Dastovich and Gabarjova to all my friends. Hello doctors, good evening. You'll enjoy it today. Jalaram Chaudhary, you'll enjoy it today. I know. I hope so and I wish so that this 25 questions, most of the ENT questions come from this particular session of 25 most important questions of ENT. Good evening, and let us start and have a countdown of 10 seconds and let us start with this particular session. Good evening all, and within 5, 4, 3, 2, 1, let us look at the first question. The first question in front of you. Let us start with the 25 most important questions. Take 1 minute to answer, solve it properly, and we'll discuss. First question in front of you. A 60-year-old male smoker since 40 years presents with change in voice in ENT OPD. Endoscopic examination was done, which revealed a proliferating mass involving arytenoids and epiglottic folds only. What shall be the management of the patient? I know I have taken such topics that are very difficult for the students. Students tend to get worried seeing these particular questions. You will get these questions today. You will enjoy these questions today. You'll enjoy the tricks today. You'll enjoy the methodologies today. Answer please. A 60-year-old male smoker since 40 years presents with change in voice in ENT OPD. Endoscopic examination was done, which revealed a proliferating mass involving arytenoids and AE folds only. What shall be the management of the patient? Answer. Majority are answering A. Some are answering D. What is the right answer? Let us look. Answer. Fatafat. Come on, man. Come on. Let us answer. Answer whatever it is. Whether it is right or wrong, it does not matter. Within the next 10 minutes, this particular thing will be done and dusted forever. Forever. Believe me, forever. Fine. Let us discuss this particular question. Let us discuss this particular question, and I will talk about how to diagnose the stage of carcinoma larynx and how to diagnose or how to manage a case of carcinoma larynx. See, what will happen if such sort of question comes in your examination? अगर ये question आपके एग्जाम में आएगा, you have to look for your golden words only. Save time, mark the answer, go ahead. That is our sole motto. What you have to do, you just have to look at your golden words. What are those golden words? Listen to me very carefully for the next 10 minutes. What you have to do. You have to do. A 60-year-old male smoker comes to ENT OPD with chief complaint of change in voice. Smoker, fine. Endoscopic examination revealed involvement of whatever X, Y, Z number of structures. What you have to see, please see. These are the mantra points that I am showing you in front of you. Look at the screen. If in that question you see only one named structure, if you see only one named structure, stage is directly T1. You have to identify the T stages only and mark the answer. Stage is directly T1. For example, listen to me. 60-year-old male smoker comes to ENT OPD with chief complaint of change in voice. Endoscopic examination revealed involvement of arytenoids only. One named structure. Stage is T1. Endoscopic examination revealed involvement of aryepiglottic fold only. Again one named structure. Stage is T1. Endoscopic examination revealed involvement of false vocal cord only. Again only one named structure. Stage is directly T1. Fine. If there is only one named structure involved in that question, if you see only one named structure, stage is directly T1. It can be T1A or T1B. Sometimes they ask T1A or T1B. Mostly they won't go for T1A or T1B. Mostly they will show only T1. If only one named structure, believe me, अगर एक ही structure लिखा हो, एक ही नाम लिखा हो, then the stage is T1. If I go ahead, any more than one named structure are involved, stage is directly T2. Any more than one named structure is involved, stage is directly T2. For example, 60-year-old male smoker comes to ENT OPD, change in voice, endoscopic examination revealed involvement of arytenoids and AE folds only. More than one named structure. Involvement of arytenoids, false vocal cord and aryepiglottic fold only. Again, more than one named structures are there in the question. Involvement of epiglottis, arytenoids, false vocal cords, true vocal cord only. Again, more than one named structures are there in the question. Stage is again T2. Any more than one named structures involved, stage is directly T2. Simple. One name structure in the question, stage is T1. More than one name structure, stage is T2. Now look at this particular question and identify what is this. Is it T1 or T2? Now look at this question. First of all, identify the T stage. Then we'll come to the management. First identify, read this question. First identify which is this T staging. Which is this T staging? What is this? Is it T1 or T2 or T3? Forget about T3. Just focus. Is it T1 or T2? Answer me very nicely. What is this? Is it T1 or T2? 60-year-old male smoker coming to ENT OPD, does not matter. I can see endoscopic examination reveal involvement of arytenoids and AE folds. I told you more than one named structure is written, so it is T2, obviously. I told you more than one named structure is written, stage is directly T2. बच्चे, for the people who are answering T1, मैंने बोला है specifically, I have told them specifically, if you see only one named structure, it is T1. If you see any more than one named structure, 2, 3, 4, 5 structure, stage is directly T2. And yes, you people are identifying it very much correctly. It is T2. Now look at the crux part. When will I label it as T3? Listen to me. If they add a line in that question, that the vocal cords were fixed or immobile, it does not matter how many named structures are involved. If this line is there, stage is directly T3. Easy. So easy. Supposedly the question says, endoscopic examination revealed involvement of arytenoids only, but it was also found that the vocal cords were fixed or immobile. Now it does not matter that only one name structure is involved. If this line is there, that means stage is directly T3. That is it. You have to look for your lines. You have to look for your golden words. Mark your answer. You will be correct. You will be correct. Since last 10 years, I am seeing the questions of NEET PG and FMG. Every time they are repeating only this line for if they have to label it as T3. As simple, as easy as that. As simple and as easy as that. Fine. Supposedly the question says, endoscopic examination revealed involvement of arytenoids and aryepiglottic folds only. You might be thinking T2, but supposedly they add one line that the vocal cords were fixed or immobile also. Stage is directly T3. It does not matter how many name structures are there in the question. Sir told us this particular same thing. I hope you got my point. I hope you got my point. And since last 10 years, they are not using these particular line. Supposedly, if they use this particular line, that there was invasion of pre-epiglottic space or paraglottic space, then also mark directly T3. They will use these specific words only. They will use these specific words only. They will use these specific words only. Remember my words. These are the golden words. These are the golden mantra points, how you will identify. How you will identify, these are the methods. Remember that. Coming, sir, when will I label it as T4? Sir, if you see this particular line I am seeing for the last 10 years, if you see this particular line, that it was found that there was invasion of thyroid cartilage. What is the stage? Stage is directly T4. It does not matter that the vocal cords are mobile or immobile. It does not matter how many named structures are there in the question. I hope you got that particular point. That is the easiest methodology. I hope you got my point. Or they will say that any extralaryngeal structure is involved. They may say external carotid artery is involved. They may say thyroid gland is involved. You know, getting my point. Any other structure which is not a part of larynx, they will say that is involved. Stage is directly T4. Stage is directly T4. I'll repeat it once, that if in the question only one named structure is there, stage is T1. That is it. If any more than one named structure is involved, stage is directly T2. Supposedly, they add a line that the vocal cords were found to be fixed or immobile, stage is directly T3. Or they can use there was invasion of pre-epiglottic space or paraglottic space. Similarly, if they use this particular line that there was invasion of thyroid cartilage or thyroid gland was involved, directly mark T4. It does not matter how many name structures are involved, whether the vocal cords are fixed or immobile, it does not matter. Similarly, let me ask you one question. If in this question I add one line, that it was found that the vocal cord were fixed, if I add this particular line in this question, what is the T staging? Answer this much only. If in this particular question I add one more line that the vocal cords were fixed, what is the T staging? Answer that much point only. If I add this line, answer only this much, and then we'll shift to the management part. I hope you got this point. I can see the right answers coming like anything. Now it does not matter, sir. You told us that it does not matter how many named structures are there. If I see vocal cord were fixed, stage is directly T3. You got that. Congratulations. Well done. First question is done. Congratulations. Now, the management part is even more easier, bachcho. Management part is even more easier. Remember my words that for all T1 and T2, treatment is radiotherapy. For all T1 and T2, mark radiotherapy only. For all T1 and T2, mark radiotherapy as the answer. Remember my words, for all T1 and T2, mark radiotherapy. Do not look for the glamorous options. Believe me, many a times glamorous options like vertical partial laryngectomy, horizontal partial laryngectomy, or number of endoscopic surgeries, are these sorts of words are written, but the easy part is for all T1 and T2, it's radiotherapy. It's as simple as that. As simple as that. And for all T3 and T4, for all T3 and T4, you have to mark total laryngectomy. For all T3 and T4, you have to mark total laryngectomy. In that option, if they give that total laryngectomy followed by neck dissection or radiotherapy, fine, you can mark that. Fine, you can mark that. But total laryngectomy should be there in the option if the question is asking for T3 and T4. I'm again repeating this point one last time. For all T1 and T2, mark radiotherapy as the answer. For all T3 and T4, mark total laryngectomy in the answer. After total laryngectomy, if neck dissection and radiotherapy things are also written, mark that. But total laryngectomy word should be there. Remember this. It has come only once if supposedly for T3 and T4, total laryngectomy is not there in the option. Supposedly, believe me, supposedly, if it is not there in the option, then you can look for the option that is concurrent chemoradiotherapy. But it is only supposedly for T3 and T4. I hope you got my point. I hope you got my point. And now you have got the management that this particular case is a stage of T2 and I will mark the answer as radiotherapy. Do not look for the glamorous options, vertical partial laryngectomy or horizontal partial laryngectomy. Do not look for these glamorous options. I hope you got my point. With that, I'll switch to the next question. I hope this is clear. I genuinely hope this particular topic, this particular segment is clear. Let us switch to the next question. We'll take it easy by easy, slowly by slowly, and we shall do 25 questions in such a way, believe me, that this session will make a huge difference. Let us go ahead. Let us look at the next question. My lovely 18-year-old patient Ramesh came to ENT OBD with chief complaints of bilateral nasal obstructions since 2 hours. Earlier, Ramesh had history of trauma to the nose due to road traffic accident. What should be the management of the case? Look at the image. I will magnify Ramesh's nose for you. I actually do not want to show Ramesh from inside, but still I'll show. Fine. Someone is asking if epiglottis is involved. Epiglottis is a part of larynx. Remember that laryngeal part of epiglottis is a part of larynx. What is the answer? It is a well-known question. I know you know this answer. It has been discussed number of times in number of questions, tests and discussions. What is the answer? What is the answer? And I can see the correct answer. Even I haven't shown the options, but still you people are correctly answering it. Yes, this is a case of what? It is a case of septal hematoma. Fantastic septal hematoma presents with a bilateral nasal obstruction. Bilateral nasal obstruction. This is septal hematoma case. Fine. And I will have to look for these 4 options, and without looking at the options, you marked it beautifully. The answer is incision and drainage. I obviously won't do functional endoscopic sinus surgery, not at all oral antibiotics. Trotter's method, it's not a case of epistaxis, it is a case of bilateral septal hematoma. Septal hematoma, remember, it is always worrisome. Why septal hematoma is always worrisome? I always say septal hematoma is always worrisome because blood is lying there close to the septum, stagnant. वो पानी की तरह खून वहां रुका पड़ा है. Blood is lying stagnant. Bacteria will come into the picture. Blood will change into pus and it will cause septal abscess. Septal abscess will ultimately lead to septal necrosis. Septal necrosis. To avoid septal necrosis, I have to do an immediate incision and drainage of this bilateral septal swelling. The case is of septal hematoma. I hope you got it. I hope you got it. I hope you got it. Yes, I hope you got it. With that, I will add one more thing. How do we manage a case of epistaxis? Believe me, when I had prepared this 25 important questions, I had prepared this thing in my mind. Along with the questions, I'll discuss some other important topics of ENT that this, what 2.5 or whatever, time it takes for this 25 most important questions, important topics are revised. How do we manage epistaxis? Remember, Mataji came to ENT OPD with her child. Child was having bleeding from nose, epistaxis. What shall be the management of this case? The first thing that you have to do, what is the first thing that you have to do? It is called as Trotter's method. It is called as Trotter's method. Believe me, let me take you back in your childhood days. Even for my Mataji also, whenever I had bleeding from nose, my Mataji used to do like this, do like this. She was feeling very happy that the blood was not coming from the nose. My Mataji was doing a drastic mistake in her life also and for my life also. Believe me, you should never do like this. Why? If you do like this, blood may trickle down into your respiratory tract and you may land up into aspiration. That is why I first do Trotter's method, that is bend anteriorly and tightly pinch the nose. Bend anteriorly and tightly pinch the nose. It will lead to vasoconstriction and the blood will come outwards from the anterior part. Getting my point? Supposedly, the patient is not getting resolved with the Trotter's method. What you can do, sir, if supposedly my patient is not relieving with Trotter's method, I will do one thing, that is Xylomist or oxymetazoline or xylometazoline nasal drops along with cold ice packs. Why will I do that? Because xylometazoline and oxymetazoline nasal drops, these are also vasoconstrictor. Fine, they cause vasoconstriction. Bleeding will reduce. Fine, and I'll put cold ice packs again. Ice or cold, it does vasoconstriction. It does vasoconstriction. And supposedly, even after doing this, my patient is not getting relieved. What shall I do? Sir, I will do some endoscopic ligation, and that endoscopic ligation is endoscopic sphenopalatine artery ligation. Why I will do sphenopalatine artery ligation? Because sphenopalatine artery is the queen of epistaxis. It is the artery of epistaxis. I suspect sphenopalatine artery is the one that is bleeding. Most of the time it is sphenopalatine artery. Most of the time it is sphenopalatine artery. Apart from that, I can do some people, in fact some books have quoted, sometimes maxillary artery or carotid artery ligation has been quoted in the books, but you don't have to go till that part. If at all the patient is not getting relieved after this, then you can go for nasal packing. For nasal packing. For nasal packing. For nasal packing. Put nasal packs. Put nasal packs. Fine. Remember that sphenopalatine artery is the artery of epistaxis, and never do like this. Pathetic method to treat epistaxis. Remember that. Pathetic method to treat epistaxis. Never ligate ICA. Obviously, ICA, internal carotid artery, is supplying the brain. Is supplying the brain. I hope you have got this particular point. I hope you have got this particular point. Epistaxis clear, septal hematoma clear, and now let us talk about this particular next question. Mataji coming with a 6-year-old child. A 6-year-old child came to ENT OPD. Before that, yeah, a 6-year-old child came to ENT OPD with chief complaints of unilateral nasal obstruction with foul-smelling discharge. What is the most probable diagnosis of the case? What is the most probable diagnosis of this particular case? A 6-year-old child came to ENT OPD, with chief complaints of unilateral nasal obstruction. Mataji has come with a 6-year-old child with unilateral nasal obstruction and foul-smelling discharge. What is the most probable diagnosis of the case? Very rightly, people are answering it very, very correctly. Very, very correctly. Remember this word. If in a child you see unilateral nasal obstruction with foul-smelling discharge, whenever you see unilateral nasal obstruction with foul-smelling discharge, it gives a diagnosis of, remember my words, what? It gives a diagnosis of foreign body nose. Very rightly said. Very rightly said. All sorts of foreign bodies I have seen in my life. Number of cases like, peanut, green peas, white peas, chickpea, paper, chalk, rubber, everything. Patient comes mostly like after 5 or 10 days and there is a very foul smelling discharge, unilateral obstruction. Diagnosis is foreign body nose. But I won't go ahead without discussing other important topics also. Can you see? This particular topic is allergic rhinitis, which is very important to me. Listen to me for the next 5 or 10 minutes. I will give you a brief idea about allergic rhinitis. Allergic rhinitis always comes, a patient if has a problem of allergy in the nose. What are the clinical features or symptoms? You might have suffered in your life. हमेशा क्या होता है जब भी allergic rhinitis होता है नाक में? Whenever we have allergic rhinitis in the nose, we have some common problems. Sir, we have nasal obstruction. Yes, sir. Sir, we have bilateral nasal discharge. Yes, sir. What else? Sir, I do continuous sneezing. Yes, sir. I continuously rub my nose like this. Yes, sir. You continuously rub your nose because you are having itching. Yes, sir. Let me go for the next 2 minutes. Let me go ahead beyond, in fact, ENT. I want to tell you the differences between the salute of Army, Air Force and Navy. Just for 2 minutes. Army salute is always like this. Believe me. Why? This salute is always like this. To show to the officer, to the high-ranking officer or to the senior that my hands are empty and are not having any weapon. In this respect, I, salute you. Air Force salute is always like this. This should go towards the sky to show to the senior that sky is our limit, sir. And Navy salute is always like this. Why? They always have to hide their hands. उन्हें अपने हाथ छुपाने होते हैं. Why? Because the Navy personnel are working in ships and submarines, So they are continuously pulling chains, continuously pulling ropes. So grease comes, that garlic or grease, they cannot show to their officer. That's why they hide their hand. Remember. Similarly, that allergic rhinitis patient came inside my OPD and was continuously, she was doing like this. I also said that thank you for saluting me. This is allergic salute. This is allergic salute. Allergic salute, a feature of allergic rhinitis. Feature of allergic rhinitis. Apart from that, I see Darier's lines and allergic shiners. What are these? काले घेरे पड़ जाते हैं आंखों के नीचे. We have darkish spots, below the eyes. We can see reddish lines over here over the nose. These are Darier's lines and allergic shiners. Remember these important points for allergic rhinitis. How do we treat it? How do we treat it? How do we treat it? Sir, most of the times, naak khule chutki mein, I give such type of drops. That is xylometazoline or oxymetazoline nasal drops. Fine, sir. But NV knows the fact that you know the treatment of allergic rhinitis. They will ask you the recent advanced treatment for allergic rhinitis. What is that? It is omalizumab. Remember omalizumab. Omalizumab is a monoclonal antibody. It is remember, it is anti-IgE antibody. It is anti-IgE antibody drug. Anti-IgE antibody drug, omalizumab. Anti-IgE. I will use this anti-IgE antibody drug because allergy is also a IgE mediated type 1 hypersensitivity reaction. I will give this omalizumab anti-IgE antibody. You have to remember this omalizumab. It is a culmination, togetherness of ENT and pharmacology. Remember that omalizumab. I hope you have got this particular point, you have got this particular question. With that note, let us go to the next question. One of my favorites, one of my patent techniques, one of my patent mnemonics coming to your side. Sinuses that will be present in a child with 2 years of age is R. Take your time, take 1 minute, answer this particular question. Sinuses that will be paranasal sinuses that will be present in a child of 2 years of age is R. Even if you answer it wrong, even if you answer it right, it does not matter. Again, I will tell you the perfect trick or methodology of how you will remember it. Sinuses that will be present in a child of 2 years of age. What is the answer? What is the answer? Some are saying B, some are saying C. What is the answer? What is the answer? For the people who are answering C, my deepest condolences to you all with a bouquet of flowers. For the people who are answering B, it is the correct answer. And I'll explain you the methodology, how you will remember this. Let me talk about this particular topic, appearances of paranasal sinuses. How you will remember it. Just listen to me for the next 5 minutes and the part will be done and dusted forever. Remember, the first paranasal sinus to develop, in fact it develops at the time of gestation itself, is always maxillary. The first paranasal sinus to develop is always maxillary. And whenever a child is born, remember, whenever a child is born, supposedly child is born at the time of birth, what are the paranasal sinuses that are present at birth? Remember, it is maxillary and ethmoid. Remember, it is maxillary and ethmoid that are present at birth. Maxillary is almost fully developed. Ethmoid is not fully developed at the time of birth. Then you may ask me, sir, when does it develop completely? I am giving you a mnemonic for that. Remember, for the people who understand Hindi, E stands for ethmoid, E stands for एक. बच्चों, 1 साल में ethmoid completely develop करता है. Ethmoid completely develops by 1 year of age, but at birth, both maxillary and ethmoid are present. Both maxillary and ethmoid are present. Now, you may ask me one fine question. Sir, can you tell me when does sphenoid or when does frontal sinus appears? The trick or the methodology is very easy. I am writing sphenoid here. Can you see this letter S is looking like a number 5? And yes, sir, at 5 years of age, sphenoid sinus appears. At 5 years of age, sphenoid sinus appears. But remember, human body should always carry a range. It's not like that if I am having a birthday tomorrow, I am turning 5 years old, immediately sphenoid sinus will appear. No, so for some, sphenoid sinus may appear little bit early. For some, sphenoid sinus may appear little bit late. So I will give a range plus minus 1, and that is 4 to 6 years of age. So at 4 to 6 years of age, sphenoid sinus appears. That easy. Easy. 5 plus minus 1, 4 to 6 years of age. Your job is done. Your job is done. Fine. Now you may ask me, sir, when does frontal sinus appears? I will again tell you one fine method or technique to remember. Can you see this frontal in front of you? Yes, sir, I can see. I will invert this letter F. It will become 7. Yes, sir. Yes, sir. At 7 years of age, frontal sinus appears. And again, I will give a range of plus minus 1, plus minus 1. So, yes, I will say it as 6 to 8. 6 to 8. That easy is remembering appearance of paranasal sinuses. I hope you got that point. I hope you enjoyed that point. I hope you enjoyed this mnemonic. That easy and that easy. And obviously, you can see by this mnemonic itself, which is the last paranasal sinus to appear, it is frontal. It is frontal. It is frontal. I hope you got it. I know you people are enjoying. I wish you people are enjoying. I shouldn't know. I wish, I hope you people are enjoying. Fine. Should we, shall we switch to the next question? Shall we switch to the next question? Congratulations. 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 My, lovely white coat soldiers you are, comrades. Let us go to the next question. Let us go to the next question. See the next question and answer it. Till that, I'll take 1 minute to drink the water. Ethmoid air cell which is present in close proximity to the optic nerve. Ethmoid air cell that is present in close proximity to the optic nerve. Ethmoid air cell which is present in close proximity to the optic nerve. I know you'll answer it correctly. I know. Congratulations. Congratulations. Perfectly answered. Perfectly answered. It is Onodi cell. Perfectly answered. It is Onodi cell. Perfectly answered. It is Onodi cell. Yes, perfectly answered. It is Onodi cell. And now I'll tell you the methodology of how you will remember all these cells, all these modifications of ethmoidal air cells. Yes, people are answering it very much correctly. I'll label one cell by one at a time. If I talk about this agar nasal cell, again जो हिंदी समझते हैं, इसके आगे लिखा है आगे. There is a word written आगे here. आगे means anterior, in front. That means the most anterior most ethmoidal air cell is agar nasal. आगे, anterior, front. Most anterior most ethmoidal air cell is agar nasal. Fine. Is agar nasal. Talking about Onodi cell, the cell which is present in close proximity to the optic nerve. How I remember it? Onodi. There are first two letters ON. That means optic nerve. Easy to remember. This cell is present in close proximity to the optic nerve. Third one, bulla ethmoidalis. Whenever I hear this word, bulla means large. Bulla ethmoidalis. Ethmoidalis means ethmoid air cell. The largest ethmoidal air cell. Bulla ethmoidalis. The largest, most consistent. The largest, most consistent ethmoidal air cell is the bulla ethmoidalis. Largest, most consistent is the bulla ethmoidalis. And one more cell that is left, is Haller cell. For Haller cell, remember my word, they will use a cell which is present in close proximity to the orbital floor. If they use this word, the cell which is present in close proximity to the orbital floor, it is Haller cell. It is Haller cell, the cell which is present in close proximity to the orbital floor. It is Haller cell. I hope all these cells are clear. Then I'll switch to concha bullosa. Then I'll switch to concha bullosa. Bulla. If I say the great Khali, you won't say that great Khali is a miniature. I am saying the great Khali. Similarly, bulla. Bulla, no, bulla. Bulla ethmoidalis. Bulla ethmoidalis, the largest, most consistent ethmoidal layered cell. With that, let us switch to concha bullosa. Let us switch to concha bullosa. Let us switch to concha bullosa. What is concha bullosa? Before that, I have to say one word. That what is a turbinate? Remember, a turbinate is a bone covered by mucosa. What is a turbinate? Turbinate is a bone. Turbinate is a bone. Remember, turbinate is a bone. Turbinate is a bone covered by mucosa. Remember that. Which is the largest turbinate? Inferior turbinate is the largest turbinate. Remember, it is just a bone covered by mucosa. It should be a bone. Like if you see this particular image, this is your what? This is your inferior turbinate. Fine. And this is your middle turbinate. But sir, how come there is air inside this middle turbinate? How come there is air inside middle turbinate? Aapne to kaha tha, you said earlier that it's just a bone covered by mucosa. Then how come there is air inside middle turbinate? This air inside middle turbinate is called as concha bullosa. Air, or we can say pneumatization of middle turbinate is what we call as concha bullosa. Concha bullosa. Fine. For the person who is asking how many questions we expect in July, bache, if we look at the last session of FMG, approximately 20 to 22 questions were there from ENT. I hope, I wish that maximum questions are there from ENT and maximum questions come from this particular session. May God give you grace. May God give you blessings. Fine. With that, I'll switch off to the next question. Before switching off to the next question, I want to say something. Believe me, I'm not that sort of a person, that, highly motivates you, say you, good glamorous, words. But I want to say you something. Like some are asking, sir, motivation. Bache, if I talk about motivation, I can draw like this. I will draw like this. What I will do, I will draw stairs like this. Fine. You are standing here. And one day you will reach there. I don't want to do this. Or sun is rising from the east every day. But one day for you only sun will rise from the west. I again don't want to do such thing. You are the biggest motivator for yourselves. I can recall 5-6 years back when I was also preparing for my NEET PG examinations. The only thing that was motivating me, remember my words. We are those white coat soldiers. Some are working very hard because they have to impress their parents. Some are working very hard because I want to earn 2 pieces of roti for day and night. Some are working because I want to become a specialist one day. Some are working hard because people, friends and relatives had doubted your capability, that why I am going outside India for studying. To prove them wrong, I am studying. That is your motivation, not these stairs and not the sun rising from the west. Keep that motivation, keep that hard feeling inside. Whenever you have that fear or anxiety in your heart, and it is okay to be anxious, it is okay to be fearful. We were having that fear when we were appearing for those pathetic 10th class examination. And this is a career deciding examination. We should have anxiety. In fact, if we are not having anxiety, that is more worrisome for me. You should have that anxiety. It is fine to have that fear. Just do not let that fear, mask your mind. And study hard. For someone is waiting. For someone means your parents are particularly waiting. No one except your parents, your brother and sister. They are actually waiting for you to clear the examinations. Do it for yourself. Do it for them. Don't do it for anyone else. It is just you and you only. Remember it. Remember it. With that, let us look at this next question. Let us look at this next question and answer this question. I, don't tend to motivate. In fact, in my live classes also, anytime I don't motivate, because it is, for me, I don't feel motivated. I don't want to feel motivated for next 10 minutes by listening words or seeing slides, because I know that back there in my mind, back there in my heart, I'm having that fear. And I have to prove everyone wrong that I am the best one. I have to prove them that I am the best one. I deserve it. I deserve to become a doctor. Let us answer this particular question. Total amplification by impedance matching mechanism of middle ear is. Answer it. What is the total? You people are rightly saying, if you know that how this answer came, I'll prove it to you today. Most of the times we were learning the 22:1, 22:1, 22:1. Today I will prove you why 22:1 came. I will take you to your 10th class physics. That is it. I will take you to your 10th class physics and you'll understand why this 22:1 came. Just listen to me for the next 5 or 7 minutes. Just listen to me for the next 5 or 7 minutes and you will get to know why this, in fact, why this 22:1 came. Now listen to me very carefully. It is all happening because of transformer mechanism or impedance matching mechanism of middle ear, that air conduction is better than bone conduction. How this 22:1 came, listen to me. In fact, I want to ask you one thing. Sound travels better in solids or air? Sound travels better in solids. But then why we people always used to remember that air conduction is better than bone conduction? The answer will come today itself. Again, I'll repeat. Sound travels better in solids, bacho. I'm talking about 10th class physics. But still, we remember it as air conduction is better than bone conduction. How? This is because of middle ear impedance matching mechanism or transformer mechanism. How it came? Listen to me. Your Boyle's on different types of law says that pressure is inversely proportional to area. Pressure is inversely proportional to area. Fine. Pressure means your intensity. Fine. Pressure means your intensity. Now look at this particular thing. As soon as I go from this large tympanic membrane to malleus, to incus, then to stapes, and lastly my small oval window, don't you think that the area is decreasing? That the area is decreasing. As I go from tympanic membrane to the oval window, my area is decreasing. If my area is decreasing, that means my pressure or intensity will increase. That means my pressure or intensity will increase. How much it will increase? That is the answer. That tympanic membrane size is 17 times the size of oval window. Tympanic membrane size is 17 times the size of oval window, and we refer to as area ratio. The area of tympanic membrane to oval window is 17 times. This is your area ratio. This is your area ratio. Fine. This is your area ratio. And supposedly, please mark my words, if in your FMG examination, they ask you, what is the area ratio of impedance matching mechanism? Don't mark 22:1. It is 17 times 1. Fine, it is 17 times 1. Similarly, as soon as I go from malleus to incus, don't you think again my size is decreasing? How much? The size of the malleus is 1.3 times the size of incus. You have your calculator and mobile phones in front of you. Multiply 17 and 1.3. Multiply them and the ratio will come out as 22:1. This is how 22:1 came. You have your calculator. You can calculate it by yourself. 17 multiplied by 1.3, the ratio comes out as 22:1, and this is how we remember it as 22:1. I hope you got that. 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 This is the first factor of impedance matching mechanism. This is the second factor of impedance matching mechanism. And the third factor of impedance matching mechanism is the curved membrane effect. Curved membrane effect means tympanic membrane is not exactly straight like this. It is little bit curved. Don't you think if the tympanic membrane was straight like this, sound is a form of energy, it would have stride and reflected back. If it was like this, it is little bit concave in shape. This is the reason why sound is taken up by tympanic membrane. That is called as curved membrane effect. That is called as curved membrane effect. I hope you got what is curved membrane effect. And the last point is phase difference between the two windows. What is this phase difference between the two windows? I'll again explain it to you. It's just basic physics, bacho. I'm not going hi-fi or I'm not talking haphazard things. It is just your 10th class physics that you're learning today. Listen to me again very carefully. Supposedly this is your cochlea. Supposedly this is your cochlea. This is your oval window. This is your oval window. And below, this is your round window. I want to ask you, if supposedly sound would have reached both oval window and round window simultaneously, sound again is a form of energy. If it would have reached oval window and round window simultaneously, don't you think they would have cancelled here each other? It is a form of energy. They would have cancelled each other. That is the reason why sound never travels to oval window and round window simultaneously. Sound always travels to oval window. Remember, sound travels to oval window before round window so that the resultants come out. It travels to the oval window first so that the resultant comes out, and this is called as phase difference. I hope you got all these 4 points, and these 4 together points, if you look at your Dhingra of ENT, this is written, this is the total transformer mechanism of middle ear. I hope you got it. You can rectify it, bacho. I don't have any issues. Anyways, we need to clear our examination, that is it. But if you want to remember the way how this impedance matching or transformer mechanism was happening, it is because of these 4 points. Calculator is in front of you. Multiply 17 into 1, 17 multiplied by 1.3, it will come out as 22:1. Curved membrane effect, it shouldn't be straight, otherwise sound will get reflected back. It should be curved. Phase difference, why phase difference is required? Because oval window sound should travel to the oval window before round window, otherwise they will cancel each other. I hope you got this particular point. This was little bit conceptual. I had taken 4 or 5 minutes extra for this particular question to explain you this particular point. With that, I will enter into the next part. And the next part is the audiogram. Believe me, for the next 10-15 minutes, just, within this next 10-15 minutes, the audiogram session will be done and dusted forever. You'll remember audiogram forever. Just concentrate for the next 10-15 minutes. Audiogram of the patient is given. 2 questions were asked from audiogram, pure tone audiogram, this particular FMG examination. Answer this. Answer this. I'll magnify it for you. I'm not even showing you the options. If you have checked this particular thing, now look at the options. What is the diagnosis? What is the diagnosis? What is the diagnosis? Perfectly people are answering noise-induced hearing loss. Bache, if you can see, there is a characteristic dip at 4000 Hertz. There is a characteristic dip at 4000 Hertz, and this is called as, if you know, this is called as acoustic dip. Remember, it is called as acoustic dip. It is also called as boiler's notch. Acoustic dip or boiler's notch. These are the words used for a characteristic dip at 4000 Hertz. And it is a feature of, yes, very rightly said, noise-induced hearing loss. And if you want to understand the complete concept or the complete trick to remember pure tone audiometry, I'll just share my trick within the next, just listen to me for the next 10-15 minutes. I'll ask you questions, then only answer. But remember how we will remember all the graphs of pure tone audiometry. Just listen to me very carefully. For the people who know, well and good. For the people who don't know, I'll tell you the methodology, how you should remember pure tone audiometry. Just write these 3-4 mantra points and you'll answer all the questions of pure tone audiometry, believe me. The first point is, remember pure tone audiometry, I have to identify 3-4 things. First, I have to identify which side of hearing loss is it. Right side hearing loss or left side hearing loss. How will I identify? That is, if the line is in red color, R for red, R for right ear. Simple. This is the first point. Similarly, blue is for left ear. First, listen to me very carefully. Even if you know, listen to me very carefully for the next 10-15 minutes and pure tone audiometry will be done. Fine. R for right. Fine. Blue color is for the left ear. Fine. This is the first thing that you have to remember. Fine. Then in that graph, there will be number of graphs that will be shown. In that graph, you have to identify whether it is a bone conduction line. See, I'll draw this particular thing. Let me draw a graph in fact. See, you'll see, if you see pure tone audiometry graph, how you will see that this is intensity of sound in decibel. 0, 25, 40, 80, like that. Fine. And this is frequency in hertz. 2000, 4000, 8000, just like that. You'll see such things. And then you will see two lines like this. Just listen to me very carefully. Then you will see two lines like this, and you have to, identify which is the bone conduction line or which is the air conduction line. बच्चों, मैं आपको बड़ा simple technique बता रहा हूँ. I am telling you one fine, easy technique. How to remember that which line is for bone conduction, which line is for air conduction. Just remember one thing. We should not go into that much detail. Just remember, always, this is the second point, always bone conduction line is the above line. जो ऊपर वाली लाइन होगी ना बच्चे, वो हमेशा बोन कंडक्शन की है. Forget about everything. Forget about everything. The upper wali line is the bone conduction line always. Easy. So that means this is the bone conduction line and this is the air conduction line, and the gap between them is called as AP gap. Air conduction, bone conduction gap. That's it. Till now I haven't discussed many things. I have just told you two things. Red is for right ear, blue is for left ear, and second, always bone conduction line is the above line. Fine. Yes, bone conduction line with open mouth. Yes. Bone conduction is always above. Forget about open close. Fine. Bone conduction line is always the above line. Forget about it. Open mouth, close, open, close, or beach ka. Forget about it. The third thing that you have to remember to understand this pure tone audiometry is, and I will draw the graph. We know the fact. Now I won't draw colors, just to explain you. This is your 25 decibel. We say that up to 25 decibel, if a person is hearing, it is normal. If you know, well and good. If you don't know, I am telling, if a person is able to hear till 25 decibel, it is normal. Supposedly, both the lines are above. That means it is normal. That means it is normal. Remember it. If both the lines are above, that means it is normal. Above 25, both the lines are above, that means it is normal. Fine? Clear? Supposedly, I am not drawing colors. I am not drawing colors. Listen to me very carefully. I'll revise it once and again and again. But this pure tone audiometry should be clear. If one line is above means bone conduction line is above, and the air conduction line goes anywhere downwards. It goes beyond 25 anywhere. This is, bachche, hamesha you have to remember conductive hearing loss. As simple, as easy as that. As simple, as easy as that. Bone conduction line is above, that means it is, normal. Air conduction line went downwards beyond 25. It is conductive hearing loss. Again, I'll add one more thing. Just two things are left. Supposedly, both the lines come downwards. Both the line. For the child bache who is asking masked or unmasked, believe me, no one will ask you what is masked or unmasked. Listen to my words very carefully. We are about to finish pure tone audiometry. If both the lines come downwards and the gap between them is narrow, and the gap between them is narrow, and the gap between them is narrow, it is sensory neural hearing loss. As easy, as simple as that. Sensory neural hearing loss. Both the lines have come downwards and the gap between them is narrow. Simple. Sensory neural hearing loss. And to label it as mixed hearing loss, I'll explain what is masked or unmasked. Mask, I'll just add this line and you specifically, you can ask later. Masking means presenting a sound to the presenting a sound to the non-test ear so that the non-test ear does not take part in the testing ear. That is masking. Why to go into that if no one will ask you? If you want to ask it specifically, you can ask it later or on my Instagram. But right now, focus here. Fine. Now, let us not break my rhythm. If supposedly I have to label something as mixed hearing loss, I should have feature of conductive hearing loss also and sensory neural hearing loss also. Feature of conductive hearing loss is high AB gap. Feature of conductive hearing loss is high AB gap, and feature of sensory neural hearing loss is both the lines have come downwards. That means in mixed hearing loss, both the line will come downward also and there will be high AB gap, and this is mixed hearing loss. I will repeat it once again. Listen to me very carefully. If both the lines are above 25, that means it is fine, it is normal. If supposedly bone conduction line is there above, fine. Air conduction line comes downward and the gap between them is high. It is conductive hearing loss. If supposedly both the line come downward, gap between them is narrow, it is sensory neural hearing loss. And to label it as mixed hearing loss, I should have both the features. That means gap between them is also high and both the lines have come downward also. This is mixed hearing loss. If you have understood till now, well and good, because now you have to answer me just conductive hearing loss or sensory neural hearing loss. I will show you different graphs and you have to answer each and everything very carefully. This is 25, 25, 25, 25, 25, 25. For your own learning, I will explain. Don't worry, I will explain if the dip is at 2. First focus here. What is this? Now, remembering all those mantra points, you have to tell me which side hearing loss is it, left or right, and you have to say, is it sensory neural, mixed hearing loss, conductive hearing loss, or it is normal. Answer first this thing. What is this? What is this? Answer me this thing. You have to identify the side and you have to identify is it normal, conductive, sensory neural, or mixed. Just answer this. Answer this. Just answer this. Answer this. I am spending time on pure tone audiometry because I regularly 7 to 8 students, 10 students always ask, sir, explain pure tone audiometry. Deliberately I had put pure tone audiometry question. I could have skipped this part to make it more glamorous session, but I want to explain you things. Side also, bache, you know it is normal. Which side? Side also, side also, side also. Which side? Which side? Normal, normal. Which side? Side, side, bache, side. Left side normal. It is blue, blue color. Left side normal. Left normal, left normal. You are getting it. You are definitely getting it. It is left side normal. You will understand pure tone audiometry within 2 minutes. Left side normal. Mantra points are done. Mantra points are done. Perfectly fine. Now you have to answer this second question. Answer this. Answer this. Yes, you are now getting it. Left side normal. Fantastic, fantastic. Answer this. Answer this. Answer this B1. Answer this B. Answer this B. Answer this B. You will get to know pure tone audiometry today. Answer this B. I'll spend time, I'll wait. Don't, no issues with me. I will, sit continuously for make you understand this particular pure tone audiometry. What is this? Gap between them is high. Sir, you told us, above line will be there, below line will come. It is right conductive hearing loss. Mantra point clear, I hope. I hope this mantra point is clear. It is right conductive hearing loss. Fantastic, fantastic. Right conductive hearing loss. Fantastic, right conductive hearing loss. Fantastic, fantastic, bacho. Now let me ask you. What is this C1? What is this C1? I have taken the most difficult parts in this particular 25 most important session so that you go in that examination hall that you know that I know ENT like anything. Those 20 or 22, whatever number of questions in ENT come, I won't lose even a single question. And that is my faith, that is my wish, and that is my hope. Answer this. C1. Fantastic. Yes, mantra points cleared. C. Right sensory neural hearing loss. Yes, yes, fantastic. Right sensory neural hearing loss. You are getting it. You are getting it. Believe me, even if you go for your NEET PhD examination later on, for your INICT examination later on, this is the way to remember. Job is done. I'll solve it. Let the non-Mistians or anyone, it should be known to everyone. Knowledge should be for everyone. We will study it together. Let me ask you. No need to worry. Let me ask you. D option, D1. Whether you are a Mistian or a non-Mistian, knowledge is for everyone. This 25 session has been kept in YouTube for our FMG fraternity, for the students of FMG fraternity. It is for everyone. Knowledge is for everyone. We all are doctors. We all are appearing for this exam. And let us answer this D1. No, बच्चे एक second. 25 is here. 25 is here. It is left mixed, बच्चे. I told both the lines have come downwards and gap between them is high. It is left mixed. Left mixed. It is left mixed. Left mixed. Left mixed. Yes. I hope you are enjoying this. Puton audiometry is this much only. Why to spend so much of time? Just see the lines over there. I know the answer. Fine. Yes, answer this. Answer this even. Even. What is this E? E. Come on. What is this even? It is right conductive hearing loss. Right conduct. Now you're thinking, just within 5 seconds I am solving the questions of Puton audiometry. Within 5 seconds I am solving the questions of Puton audiometry. Within 5 seconds I am solving the questions of Puton audiometry. And lastly, let us look at this F1. Let us look at this F1. What is this F1? Yes, bacho, E is right conductive hearing loss. Now I can see your enthusiasm and energy coming out. What is this F1? Now I think Puton audiometry is done, dusted, clear like anything. Yes, yes, yes. What is this F1? What is this F1? It is left side normal. Congratulations. Left side normal. Congratulations. I'm glad. I'm very happy. Congratulations. I'm glad and very happy. It is. Yeah, you are done. Done. Bache, I can see perfect right answers coming like anything. It is left normal. Yes, Puton audiometry is done. Now, there are some special conditions of Puton audiometry. Only those you have to remember that you were asking dip at 2000, dip at 4000. Now you have to, yes, left side is normal. Perfectly fine. Now remember, before going ahead with the special conditions of Puton audiometry, I am telling you one fine trick. Whenever there is any problem in the external or middle ear, it will produce conductive hearing loss. Just remember that. Whenever I have any problem in the external or middle ear, I will have conductive hearing loss, and beyond middle ear, that means inner ear and the neural pathway, I will have sensory neural hearing loss. That's it. That is the only thing. Before going ahead with the special things that you have to remember for Puton audiometry. That is the thing. Whenever I have problem of external and middle ear, it will produce conductive hearing loss. And whenever I have problem of, cochlea or neural pathway ahead, it will produce sensory neural hearing loss. One person rightly asked, if supposedly it comes in, apart from the red or blue, it comes as black or white. But if it comes in black or white, they'll ask you directly the special conditions. They will directly ask you the special conditions. But mostly, I always believe color is always given. Actually, in this question also, the question that I had asked, it is actually in blue. You cannot appreciate that blue, but this is blue. Fine. Puton audiometry, if it comes, color should be given. Otherwise, the special conditions you have to remember. What are the special conditions? Now comes the special conditions that you were asking for. Sir, if there is a characteristic dip at 2000 hertz, it is called as Carhart's notch. Carhart's notch is seen in what? Otosclerosis. These are the special conditions. After that, PT is done. Carhart's notch, if there is a characteristic dip at 2000 hertz, it is called as Carhart's notch, seen in otosclerosis. Similarly, bache, remember it. Similarly, I will draw acoustic dip here. Similarly, if there is a characteristic dip at 4000 hertz, you know that it is basically called as acoustic dip or boiler's notch, seen in noise-induced hearing loss. Noise-induced hearing loss. Fine. Noise-induced hearing loss was the question that was asked in your FMG examination that happened this time. And the next question was also asked in your FMG examination that happened last time. It was the rising curve. Remember, if you see a graph like this, that the curve is rising like this. Rising curve is a feature of, remember, Meniere's disease. Is a feature of Meniere's disease. Rising curve, this was asked in your FMG examination that was, that happened this time. It is Meniere's disease. Rising curve is a feature of Meniere's disease. Similarly, if you see a downsloping curve, this is this downsloping curve. Downsloping curve is a feature of presbyacusis. Fantastic. Presbyacusis. Downsloping curve is a feature of presbyacusis. It's a feature of presbyacusis. Is a feature of presbyacusis. I genuinely, I am feeling very happy that this Peotone audiometry, every day I was receiving number of questions, sir, explain PTA, but you people had answered PTA very rightly, and the concept of Peotone audiometry are done. Remember, at last, U-shaped or cookie bite is seen in congenital deafness. U-shaped or cookie bite is seen in congenital deafness, and this is the whole Peotone audiometry done and dusted. Let us enter into the next question. I don't know, I had spent approximately, half an hour or 45 minutes for, I don't know, it does not matter. For you, though, actually it does not matter. For your career, though, actually it does not matter. It is very important to understand these things. And the next question is in front of you. A 60-year-old male patient came to ENT OPD with neck nodes. Patient also complained of decreased hearing from left ear with tympanogram suggesting B type of tympanogram. What is the most probable diagnosis? What is the most probable diagnosis? What is the most probable diagnosis? A 60-year-old patient came to ENT. I know that you'll answer it correctly. Yes, very rightly said. ठीक आ रहा है जवाब आपकी तरफ से. Very rightly said. It is none other than your nasopharyngeal carcinoma. It is none other than your nasopharyngeal carcinoma, and I'll tell you 4 or 5 basic important points that each and every candidate should remember for nasopharyngeal carcinoma. NPC. NPC is nasopharyngeal carcinoma. NPC is nasopharyngeal carcinoma. These are the important points that you have to remember for NPC, nasopharyngeal carcinoma. NPC. NPC, nasopharyngeal carcinoma. Firstly, it is a very, very highly radiosensitive tumor. It is a very highly radiosensitive tumor. It is a very highly radiosensitive tumor. Second point, that it is associated with a virus that is also responsible for your kissing disease. Kissing disease, infectious mononucleosis, and that is none other than your Epstein-Barr virus. Your Epstein-Barr virus. Fine. Third point, the most common site for the nasopharyngeal carcinoma is the fossa of Rosenmuller. Fossa of Rosenmuller is the site of origin or the most common site for the nasopharyngeal carcinoma. For the nasopharyngeal carcinoma. And lastly, and the mnemonic says NPC, nasopharyngeal carcinoma, and the triad is Trotter triad with a mnemonic NPC, where N stands for neuralgia, P stands for palatal palsy, and C stands for conductive hearing loss. Nasopharyngeal carcinoma, NPC, mnemonic is also for Trotter's triad, NPC, Trotter's triad, NPC, neuralgia, palatal palsy and conductive hearing loss. Remember, this palatal palsy is ipsilateral. Remember, it is ipsilateral. Fantastic, fantastic, fantastic. Fine. Remember, the most common presentation of nasopharyngeal carcinoma, the most common presentation of nasopharyngeal carcinoma is neck node or neck swelling. Or neck swelling. Yes, fantastic. Yes, unilateral. Very good, very good. Congratulations, very good. Neck nodes or neck swelling is the most common presentation of nasopharyngeal carcinoma. Fantastic, fantastic. Very good. Very good. Fantastic. And if you know the next question, well and good. Yes, yes, yes. And if I talk about the treatment part, remember, it is a very highly radiosensitive tumor. The treatment is chemoradiotherapy. Chemoradiotherapy, which is a better option than radiotherapy. Remember that. Remember that. Fine. Remember that. Chemoradiotherapy better than radiotherapy. Let us come to the next question, and the question is in front of you. Bill's bar separates. If you know Bill's bar, well and good. If you don't know, still also well and good. You'll know it today because it has been asked both in NEET PG and FMG examinations, both. Very important. What is Bill's bar? And I'll make you understand and in fact give you a mnemonic to remember Bill's bar if you don't know. Answer this question. Bill's bar separates. What is the answer? Bill's bar separate. Come on, come on, come on. White coat soldiers, comrades, come on, answer this question. सरहद पे जो वर्दी खाकी थी अब तो उसका रंग सफेद हो चुका है. Comrades, चलो आंसर. Bill's bar separate. Bill's bar separates. Yes. Some are answering A. My deepest condolences to them. Some are answering B. My even more deepest condolences to them with a bouquet of flowers. For the people who are answering C, congratulations. C is the right answer. And let me explain you what is Bill's bar. What is Bill's bar? And how I remember Bill's bar. I will draw a diagram of IAM. IAM stands for internal acoustic meatus. If you don't know, don't worry. I will draw a diagram of internal acoustic meatus and you will understand what is Bill's bar. This is internal acoustic meatus in front of you. There is a horizontal line separating this internal acoustic meatus which is called as falciform crest, which is called as falciform crest, which is called as falciform crest, which is called as falciform crest. Fine. Then there are four important nerves. Here there is seventh nerve. Seventh nerve is what? Facial nerve. It is facial nerve. Seventh nerve is facial nerve. Fine. Here there is cochlear nerve. Here there is cochlear nerve. Above is seventh nerve, that is a facial nerve. Below is cochlear nerve. Then here is obviously superior vestibular nerve and below is inferior vestibular nerve. Fine. And this is the location of Bill's bar. And this is the location of Bill's bar. How I remember this complete internal acoustic meatus? Listen to me very carefully. You might have consumed a cold drink called as 7-Up. 7-Up cold drink. 7 is up. and coke is down. Coke is down. 7 up, coke down. 7 up, coke down. Fine. Obviously 7 is up, coke is down. Fine. And obviously superior vestibular nerve will be superior and inferior vestibular nerve will be inferior. Fine. So Bill's bar is the one. Bill's bar is the one that separates 7th nerve, facial nerve, with the superior vestibular nerve. Fine. And this is the diagram that you can see in front of your picture. 7 up, coke down. Fine. I hope Bill's bar is clear. I hope Bill's bar is clear. This is the vertical bony crest or the vertical bony septum that separates your 7th, that is the facial nerve, from the superior vestibular nerve. I hope this is clear. 7th nerve, that is a facial nerve, separates from the superior vestibular nerve. डर के आगे तो सच में जीत है. I hope this is clear. I hope this is clear. Fine. And now comes a very nice clinical part that is coming in front of your screen. And this was my introductory video also. Question is in front of your screen. And I'll teach you a clinical thing today. Me being a consultant at Apollo Hospitals, Delhi NCR, I want to teach you some clinical things also that you will remember for life. That you will remember for life. Answer this question. Trotter's sign is a feature of. You have studied Trotter's method, you have studied Trotter's triad, and you will be seeing Trotter's sign now. What is Trotter's sign? Trotter's sign is a feature of. Trotter's sign is a feature of. I knew that you will, mark this question incorrectly, and this was my introductory line when I had given this for MIST. There is a difference between Trotter's method, Trotter's triad, and Trotter's sign. Right now I am asking Trotter's sign, and that's why I had given the options A, B, C. A is Epistaxis, where you see Trotter's method. B is your Nasopharyngeal Carcinoma, where you see Trotter's triad. And lastly, there are conditions where you see Trotter's sign. What is Trotter's sign? To understand this, just listen to me for 2 minutes. I'll make you perform something. You remember it for life. You remember it for life. See, do like this. Do like this. Fine. And extend your neck and keep it over here at your larynx. Do like this. Keep it here over your larynx. Fine. Now push the larynx backward and move it sideways. Do it, everyone. Do it, everyone. Push the larynx behind and move it sideways. Good. Do it, everyone. I'll teach you a clinical thing today. Can you feel a good grating sensation, bone rubbing sensation? Do like this. Good, grating sensation. Feel that sensation. I want to make you feel that sensation because I will give you a very nice thing today. Can you feel that sensation? Good. You feel that bone rubbing sensation. You push it backwards, move it sideways. If you are not feeling it, my deepest condolences. There are chances of laryngeal carcinoma that has extended to post-cricoid region, my friend. So better palpate it and check it by yourself. Can you feel it? That bone rubbing good sensation. Feeling? That is called as laryngeal crepitus. That is called as laryngeal crepitus, which is normal. Which is normal, remember my friend, which is normal. And if you are not feeling it, it is called as Trotter sign, also called as Boca's sign. Fine. Fine. If you are not feeling it, that is called as Trotter sign or Boca's sign. That the sensation, that gut bony sensation, bone rubbing sensation that you are feeling is called as laryngeal crepitus. It is normal. It is normal. And absence of laryngeal crepitus is called as Boca's sign or Trotter sign, seen in only 3 conditions that you have to remember, bachcho. Seen in only 3 conditions. One is my favorite, laryngeal carcinoma. Laryngeal carcinoma that extends to post-cricoid region. Laryngeal carcinoma that has extended to post-cricoid region, there you won't feel laryngeal crepitus, Trotter sign positive. Fine. What is the second condition? That is prevertebral abscess. And lastly, retropharyngeal abscess. These are the 3 conditions where laryngeal crepitus is absent. Absence of laryngeal crepitus is called as Boca's sign, also called as Trotter sign. And these were the 3 Trotters. Trotter's method in epistaxis, Trotter's triad in nasopharyngeal carcinoma, and Trotter's triad in these 3 conditions. Sorry, Trotter's sign in these 3 conditions. Trotter's sign is seen in these 3 conditions. This is a clinical thing. Remember, my friend, whenever you see a very old smoker with a change in voice coming to you, ask them to do like this. If not, in fact, do not ask them. You have to palpate and do like this. If you do not feel that grating sensation, that means laryngeal crepitus is absent, and there are chances that there is laryngeal carcinoma that has extended to post-cricoid region. I hope it is clear. I hope you are liking it. This is a very nice clinical thing I wanted to teach you. With that, I will enter into the next question. Next question in front of your screen. Next question. Next question, man. Hennebert sign is a feature of. Hennebert sign is a feature of. Answer. Hennebert sign is a feature of Meniere's disease and congenital syphilis. I'll explain you what is Hennebert sign. Hennebert sign is a feature of Meniere's disease and congenital syphilis. Hennebert sign is a feature of Meniere's disease and congenital syphilis, and let me explain it to you. What is Hennebert sign? For understanding Hennebert sign, you have to understand something called as fistula test. Let me explain you what is fistula test. First of all, remember what is fistula? Fistula means an abnormal communication. Fistula means an abnormal communication between the 2 regions. Fine. If there is a fistula between middle ear and inner ear, that means fistula test will come out positive. If there is an abnormal communication between middle ear and inner ear, fistula test will come out positive. How do you do that? You will press the tragus alternatively like this. Fine. You will press the tragus alternatively like this. Fine. This will create changes in the middle ear pressure, and if fistula is present, patient will have vertigo. And if we are normal, we won't have any vertigo. Thank God, congratulations to me that I am normal. Negative in normal people, positives like in cases of cholesteatoma. Fine. And remember, false positive fistula test seen in Meniere's disease and congenital syphilis is called as Hennebert sign positive. Remember that. False positive fistula test for Meniere's disease and congenital syphilis is your Hennebert sign. Fine. And false negative fistula test is seen in cases of dead labyrinth. Remember that. Dead labyrinth. Remember that. Dead labyrinth. Remember that. Someone is saying Hitzelberger. Bacha, Hitzelberger is different. It is seen in acoustic neuroma. Remember, Hitzelberger sign is seen in acoustic neuroma. This is Hennebert sign. I am also normal. Congratulations to both of us. And with that, let us answer the question on newborn screening for hearing. I will explain this concept of newborn screening for hearing. Thank you so much, Dr. Nishant. Which of the following statements regarding newborn screening for hearing are correct? OAE should be done, otoacoustic emission should be done after 24 hours of life. Second, BERA is the screening procedure of choice for high-risk baby. Third point, BERA is usually done after third month of life for a newborn baby. Fourth option, all of the above. Answer this question. Newborn screening of hearing is very important, particularly I feel that this is a very high chance question. You should remember newborn screening for hearing because government is taking all sort of steps for newborn screening for hearing. Answer this. If you know, well and good. If you don't know, within the next 5 minutes, you will understand the concept of newborn screening for hearing. I will explain you the concept of newborn screening for hearing. With that, I want to explain you something. Whenever a child is born, you should go for newborn screening for hearing. We should check क्या ये बच्चा सुनेगा आगे चल के नहीं सुनेगा, whether this child will hear for life or not, because early the diagnosis, early will be the treatment for that child. How we do that? We do it by a test called as OAE. OAE stands for otoacoustic emissions. We'll come to that question after understanding this complete concept of newborn screening for hearing. We will understand this concept, just one slide, all your concepts of newborn screening for hearing will be clear. Don't worry, man. Don't worry. We will understand. Screening of a newborn child for hearing is done by a test called as OAE, otoacoustic emission. When should we do it? Supposedly, a newborn child has been born. Let that newborn child should be with the mother for the first 24 hours. Why? That child should be with the mother for the first 24 hours because that child will receive that breast milk colostrum. It contains IgA antibodies and it does not look good that I enter inside that picture. Let that mother and child be together. And I'll be that disturbing agent and I'll enter inside that area or the chamber after 24 hours or first day of life. We should not do this OE test within 24 hours. Within 24 hours, let mother and child be together, and after that, a bigger child will come into the picture after 24 hours or first day of life for the otoacoustic emission of the child. It should be done after 24 hours of life or first day of life. Fine. You may be asking, sir, supposedly after 24 hours or first day of life, I as a parent miss. Till how long, what is the period of time, like I can go on 10th day, 15th day, 20th day, can I? Yes, sir, you can go till first month of life. Better go for otoacoustic emission till first month of life. It should be definitely done by first month of life. It should be definitely done by first month of life. It should be definitely done by first month of life. Fine. It should be definitely done by first month of life. Remember that. It should be done by first month of life. Now the question arises, sir, I am a parent. I forgot to go to ENT specialist or audiologist for OE. 3 months have passed. What should I do? Ma'am, if you have reached a stage where you have entered into the 3rd month, go for directly BERA. Now no use of going for OE. Remember my words. If 3rd month has come, you have to go for BERA. OE, no chance. Go for BERA. BERA stands for Brainstem Evoked Response Audiometry. I hope you might be knowing that. So I'll repeat this point. After 24 hours of life or first day of life, you have to do OAE. OAE stands for otoacoustic emissions. Till how long it can be done? It should be done till first month of life. Don't go beyond that. If I have entered into a stage where 3rd month of life has come, can I do OE? No, I have to go for BERA. But very important thing that has been asked in NEET PG and INI-CET, and FMG particularly is waiting for this particular point. Remember, for a newborn child or a newborn child in ICU, NICU, a high risk baby, preterm baby, any high risk condition baby, directly go for BERA immediately after the birth. Now no role or no use of OAE. If a child has been born and he or she is not normal, he or she is a high risk baby, directly go for BERA. If the child is normal born, then you have to go for OE. I hope these points are clear. I'll repeat these points once again. Immediately after the child is born, within 24 hours, don't do anything. After 24 hours, do OAE. It should be definitely done till first month of life. If you have entered into 3rd month of life, now no use of doing OE, go for BERA. And lastly, if the child is born with a high risk condition, high risk baby, any meningitis or any condition for which that child is in NICU or ICU, directly go for BERA. Directly go for BERA. I hope these conditions are clear. The options are not confusing, bache, because for the first time, all of the above is the answer. OE should be done after 24 hours of life. Yes, it is correct. Now look at this question. BERA is the screening procedure of choice for high-risk baby. Again, this statement is also correct. BERA is usually done after 3rd month of life. Yes, this statement is also correct for a newborn normal baby. So finally, all the 4 options are correct, or all the 3 options are correct. So all of the above is the answer. BERA can be a screening or a diagnostic procedure. Remember that. But most of the times, BERA is the final gold standard procedure. So we most of the time say it is a sort of a gold standard diagnostic procedure. But BERA can be a screening procedure also. Screening procedure for a high risk baby. Remember that. I hope this concept of newborn screening for hearing is clear. And why do we do it? Early the diagnosis, early will be the management of that child. Remember that. With that, let us enter into the next question. I know you people must be waiting for it. That X-ray nose and penis, when will it come? Remember it. Which X-ray nose and paranasal sinuses view is best for ethmoid sinus? Which X-ray nose and paranasal sinus view is best for ethmoid sinus? Answer this. Which X-ray nose and paranasal sinus view is best for ethmoid sinus? Answer this. Which X-ray nose and paranasal sinus view is best for ethmoid sinus? हाथ से नहीं फंसोगे, डोंट वरी. Yes. Very rightly said. Most of the people are answering the option number B. It is the perfectly fine correct answer. It is the Caldwell's view. Let us understand the whole concept of X-ray nose and paranasal sinus view. I am showing you something on this particular screen. Remember it. First of all, I'll talk about Waters view. If I invert this W, it will become M. So Waters view is best for maxillary sinus. Remember it. Waters view is best for maxillary sinus. And the other name of Waters view, remember, it is OM. OM stands for bachar occipitomental. Remember that. This OM stands for occipitomental. Waters view is also called as occipitomental view. Remember, it is best for maxillary sinus. Second point, Pierce view. Second point, Pierce view. Pierce view is also called as water with open mouth. It is best for sphenoid sinus. It is best for sphenoid sinus. It is the best for sphenoid sinus. Remember, my friend, it is best for sphenoid sinus. And lastly, Caldwell view. Caldwell view is best for frontal and ethmoid sinuses. Most of us knew this particular thing for our entire life. But NBE changed the question pattern for the very first time in this particular FMG examination, and they had shown you such sort of images. And they had asked which is this particular view, Waters view or Caldwell's view. How you will identify? I want to say you one simple important thing. If the chin is up, X-ray film is like this. Fine. If the chin is up, it is Waters view. Remember, if the chin is up, it is Waters view. Beam will come from behind. Fine. And if the chin is like this, if the film is kept here and my head is like this, it is Caldwell view. Remember, if the chin is like this, it is Waters view, and if it is like this, it is Caldwell view. Remember, my friend, remember. Again, like in this picture, chin is here, it is Waters view. Remember, Waters view, Caldwell view. Clear? I hope this is clear. I hope this is clear. Let us come to the next question. And in fact, yes, let us come to the next question. And in fact, before seeing this particular question, I want to show you the image because it is an image-based question coming to your screen. First of all, see these two images, image 1 and image 2. I want to ask you first thing. First look at image 2 and tell me which side tympanic membrane is this, right side or left side. Answer this much thing only. Then we'll come to the question. Look at the image 2 and answer me whether it is a right side tympanic membrane or a left side tympanic membrane. Answer me only this thing, whether it is a right side tympanic membrane or a left side tympanic membrane. I hope you got this particular point that this is, first look at image 2. I know, all sorts of tinea vermicularis are, revolving around your anal canal to answer image 1 is cholesteatoma. First look at image 2 and tell me what side of the tympanic membrane is this, right or left side? I want to tell image 2 is a left side tympanic membrane. How we remember it? How we identify it? You might be knowing, we see just cone of light. See, can you see the cone of light? And if I see the cone of light position, by the cone of light position, I identify whether it is a right side or a left side. Fine. whether it is a right side or a left side, by looking at the cone of light. If the cone of light, remember, if the cone of light is in 5 o'clock position, it is right side tympanic membrane, and if it is in 7 o'clock position, it is left side tympanic membrane. Remember this, right side and left side. Here cone of light is in 7 o'clock position, so it is left side tympanic membrane. Fantastic, your job is done. Now look at image 1. Fantastically, you people have identified that this greasy, whitish, bad looking thing is actually cholesteatoma. Remember, my friend, cholesteatoma is a misnomer. It is not a oma, it is not a tumor. Still, it is referred to as cholesteatoma because of its excessive growth and it destroys structures. Now check the question. All of the following statements regarding the two images are correct except image 1 is most probably cholesteatoma, correct statement. Image 2 is left side tympanic membrane. Yes sir, it is left side tympanic membrane. Prusac space is the most common site for image 1. Yes sir, Prusac space is the most common site for cholesteatoma. That is also fine. Image 2 is a right side tympanic membrane. No, it is the wrong statement. This is the option that you have to mark. This is the option that you have to mark. I hope this question is clear. Fine. I hope this question is clear. Fine. Fine. With cholesteatoma, in fact, before discussing cholesteatoma, I'll tell you some important points that you have to remember for tympanic membrane and its parts. If you know, well and good. If you don't, still you can learn. Just 2 or 3 minutes I'll take. That this tympanic membrane is divided into lower 2/3, that is called as pars tensa, and upper 1/3, that is called as pars flaccida. Lower 2/3, that is called as pars tensa, and upper 1/3, that is called as pars flaccida. The other name of pars flaccida is called as shrapnel's membrane. Remember, shrapnel membrane. If you know that why the lower one is called as pars tensa or upper one is called as pars flaccida, just allow me 1 minute. Actually, tympanic membrane, that is pars tensa, it is made up of 3 layers. Outer epithelial, middle fibrous, and inner mucosal layer. Tympanic membrane, that is this pars tensa is made up of 3 layers: outer epithelial, middle fibrous, and inner mucosal layer. And this middle fibrous layer, that is providing the strength to this tympanic membrane. That is why I call it as pars tensa. Tensile strength is high, and this middle fibrous layer is absent in case of pars flaccida. That's why it is called as flaccid. Pars flaccida, it is made up of 2 layers. Why? Because middle fibrous layer is absent. Remember why they are called as pars tensa and pars flaccida. I hope you got this particular point, and with that you just have to remember these important theories. I have a gut feeling these are very important for your FMG examination. These theories you have to remember. Just see these particular theories and see the theories that have been given. Retraction pocket formation theory was given by Whitman. This is the first theory. This is the theories for cholesteatoma. I hope you know. You have to remember all these 4 things. Secondly, Rudy's gave basal cell hyperplasia theory. Sades gave squamous metaplasia theory. And lastly, Haberman gave epithelial migration theory. All these 4 theories are very important, bachcho. Remember this. All these 4 theories, names and these people who had given it is very important. If you know that Whitman's theory is the most accepted theory. It is the most accepted theory, remember that. It is the most accepted theory or most accepted hypothesis. With that, let me enter into the next question. Type 2 tympanoplasty is, and with that, in this question, I'll give you a fantastic mnemonic or a trick or methodology to remember how you should know all the types of tympanoplasty. First answer this particular question. Type 2 tympanoplasty is. Type 2 tympanoplasty is. Type 2 tympanoplasty is. One fine methodology to remember tympanoplasty or classification of tympanoplasty is coming to your screen. You know that in tympanoplasty, we keep a graft. Where we will keep a graft is the classification of tympanoplasty. Answer this question. Type 2 tympanoplasty is. Type 2 tympanoplasty is. If you know this concept, how you remember, well and good. If you don't know, I'll make you remember. Just give me 5 minutes. I'll make you remember this particular thing. For the people who are answering different answers, I want to, in fact, I don't want to, discourage you, but the answer is myringoincudopexy. And believe me, don't worry, just relax. This session has been made so that you learn things. I have not included those things that you already know. Particularly, I have included the difficult things that you don't know, and it helps you that you get that confidence when you land up into your examination day. How you will remember the classification of tympanoplasty? Just listen to me very carefully, and the concept will be clear like anything. Just remember this word, just remember this mnemonic. Supposedly, this is the tympanic membrane that is perforated. This is the tympanic membrane that is perforated. And here are my malleus, incus, stapes, oval window, round window. This is my tympanic membrane that is perforated. And after tympanic membrane, we have malleus, incus, stapes, oval window, round window. And now listen to me very, very carefully. What happens that we will keep a graft? If I keep a graft over malleus, bachcho, remember, easy, Misor. Can you see Misor? Misor, M-I-S-O-R. M-I-S-O-R. Malleus, incus, stapes, oval window, round window. If I keep a graft over the malleus, fine, this graft will be taken ahead and this perforation will close. Fine. This is type 1 tympanoplasty. This is type 1 tympanoplasty where I am keeping a graft over the malleus and it is called as myringoplasty. Type 1 tympanoplasty is myringoplasty. Just listen to me for the next 3-4 minutes. This concept will be clear. Fine. If I keep a graft over malleus, fine. If I keep a graft over the malleus, it is type 1 tympanoplasty, that is myringoplasty. Fine. Sir, supposedly my malleus is eroded or my malleus has been removed. Can I keep a graft somewhere? Now listen to me very carefully. Can I keep a graft somewhere? Yes, sir. You can keep a graft over the incus. And this is called as myringoincudopexy, type 2 tympanoplasty. I have kept the graft over the incus, myringoincudopexy. This is type 2 tympanoplasty. As simple, as easy as that. Misor, malleus, incus, stapes, oval window, round window. Are yes or no? Yes, sir. Sir, supposedly my incus is also eroded or my incus is removed. Can I keep a graft somewhere? Yes, sir. You can keep a graft over stapes suprastructure. Yes, sir, you can keep. So it is myringostapedopexy. Name suggests everything. This is type 3 tympanoplasty. This is type 3 tympanoplasty. Isn't it easy? This is type 3 tympanoplasty. Sir, supposedly my stapes suprastructure is also eroded. My stapes suprastructure is also eroded. Can I keep a graft somewhere? Sir, foot plate bacha hai. Is foot plate left? Yes, sir, foot plate is left. Keep a graft over foot plate. Keeping a graft over foot plate is on foot plate. This is type 4 tympanoplasty or columella tympanoplasty. Fine. And lastly, sir, supposedly, if my foot plate is also eroded, sir, if my foot plate is also eroded, can I keep the graft somewhere? No worries. You can keep a graft close to oval window, round window. Oval window and round window are orifice. Chhed hai, yes or no? These are orifice. Orifice means fenestra. That's why I can say I can keep a graft close to oval window, round window. That's why it is called as fenestration surgery. I'm keeping a graft over the fenestras. Fenestration surgery. As simple as that. And this is your Wolstein's classification of tympanoplasty. You just have to remember Mesor. Keep a graft over malleus, that is myringoplasty. If you keep a graft over incus, myringo-incodopexy. If you keep a graft over stapes myringo-stapedopexy. If I keep a graft over footplate of stapes, on footplate. And lastly, if I keep a graft over the fenestra, that means oval window and round window or fenestra, it is called as fenestration surgery. Name suggests everything. Sir, it was very difficult for me. It is the easiest for you all, remember it. It is the easiest for you all. It was given by a famous person, Wolstein. That's why called as Wolstein's classification of tympanoplasty. Lastly, remember there is something called as type 6. It is called as sono-inversion. This is as simple as that. Names suggest everything. I don't know how and why it was difficult. It is as easy, as simple as that. Fine. I hope this part is totally clear. Let us enter into the next question. Low tracheostomy is indicated in. Low tracheostomy is indicated in. Low tracheostomy is indicated in. Comrades, white coat soldiers. Yes, bache, this I particularly I have kept this session where the most difficult part I have kept so that it makes your life easy. Low tracheostomy is indicated in. Low tracheostomy is indicated in. Answer. Low tracheostomy is indicated in. विद्यार्थियों, low tracheostomy is indicated in. For the people who know, well and good. For the people who don't know, low tracheostomy is indicated in foreign body aspiration. Remember that it is indicated in foreign body aspiration. Low tracheostomy is indicated in foreign body aspiration. I want to just give you some little bit extra knowledge. Again, clinical thing. Again, that clinical consultant things of Apollo are coming out. So, forbid me for that. Do you know what is the difference between ectomy, otomy and ostomy? Without wasting a time, I want to tell you, ectomy means removal, appendicectomy, appendix taken out, removed. Fine. Cholecystectomy, gallbladder taken out, removed. Otomy means just creating orifice, like myringotomy. Just creating orifice is otomy. And what is ostomy? Remember, ostomy means that orifice, if connected to external environment, is called as ostomy. Like in general surgery, you might have studied ileostomy, ileum taken outward for stool removal. Colostomy, colon taken outward for stool removal. I'll also do tracheostomy, where via tracheal tube, I'll take trachea out to the external environment. That's why I say it as ostomy. With that, low tracheostomy is indicated in foreign body aspiration. The questions that are important for tracheostomy, please remember: high, mid, and low tracheostomy. High tracheostomy is done between the first and the second tracheal ring. First and the second tracheal ring. It is done in cases of laryngeal cancer, laryngeal carcinoma, where the patient is planned for total laryngectomy. I do high tracheostomy. Secondly, mid tracheostomy The most common tracheostomy is the mid tracheostomy. It is done between the second and the third tracheal ring. It is the most common one. The most common tracheostomy is the mid tracheostomy that you have to remember, my friend. And lastly, low tracheostomy. Low tracheostomy is done between the third and the fourth tracheal ring. Done between the third and the fourth tracheal ring. It is done in cases of foreign body aspiration. Foreign body aspiration. Remember. And one important thing that you have to remember for tracheostomy, one very important thing that you have to remember, if they say there is a complication of tracheostomy, that is surgical emphysema. Why does it happen? It happens because of tight suture. So surgical emphysema happens because of tight suture. Remember. These are the important points that are commonly asked for tracheostomy that you have to remember, my friend. I hope it is clear. Preferably if they're saying, like, they'll say specifically between the first and the second. You cannot do a tracheostomy in the first tracheal ring. You never do in the tracheal ring. You do between tracheal rings. Fine. So they specifically, they'll mention between first and second, second and third and fourth. Fine. I hope this is clear. Tight suturing leads to surgical emphysema. How do we treat it? Just loosen the sutures, my friend. Let us enter into the next question zone. It is one of your favorite image that you can see. Which among the following statement is incorrect regarding the disease related to the given image? First, look at the image. If you can identify, it is an epiglottis, rolled up epiglottis. If you can identify this image and identify this disease, approximately, once or twice, particularly once in a month or in 2 months, at Apollo we see this particular case. Which among the following statement is incorrect regarding the disease related to given image? First, identify. This is the image of epiglottis rolled up. If you can identify, yes, perfectly fine. It is omega-shaped epiglottis of laryngomalacia. Omega-shaped epiglottis of laryngomalacia. Now check which is the incorrect statement. It is the most common congenital anomaly of larynx. First statement. Second, presents with inspiratory stridor. Okay. Third statement, characteristic turban-shaped epiglottis is seen. Okay. Cyanosis decreases with prone position of child. Okay. Which is the incorrect statement? Answer the statement. Answer the statement. Which is the incorrect statement? If you can identify, comrades, the incorrect statement is the option number C. C is the incorrect statement. C is the incorrect statement. Yes, very rightly said. C is the incorrect statement. I want to tell some important points that you have to remember for laryngomalacia. Yes, it is the most common congenital anomaly of larynx. It presents with the omega-shaped epiglottis, remember. It presents with the omega-shaped epiglottis, remember. Fine. It presents with inspiratory stridor. Fine. Child has cyanosis. And fine, immediately, whenever the child has cyanosis, what you should do, make your child into prone position and cyanosis will decrease or disappear. Remember that. Cyanosis will decrease or disappear. Fine. Whenever such thing happens, mother asks me, most of the times I'll tell you the clinical picture what happens. Mother is lying here, she has delivered a child, one obs-gynae is standing here, pediatrician is standing there. What happens? I enter the picture. They say the child is having cyanosis. They make a, we together make a diagnosis. Okay, it is a case of laryngomalacia. Mother or someone asked me, sir, what has happened to the child? Don't worry, an MCQ has happened to a child. What is the MCQ that has happened to my child? The MCQ that has happened to my child is laryngomalacia. It decreases with prone position. Cyanosis decreases with prone position. What you have to do, just reassure, calm down the parents, just say them, sit back and relax. Whenever such sort of thing happens, Just make your child into prone position. Sir, till how long should I wait? Ma'am, you have to wait till 2 years. Wait till 2 years. Mostly, this problem will go away as the child's strength will be gained back. So you have to do such sort of maneuver till 2 years. Wait till 2 years. If after that the child is not relieving, I'll be more than happy because the patient may come for surgery. Fine. Anyways, I won't go into depth of it, but fine. I have to wait till 2 years. These are the important points that you have to remember. And my favorite, one of the favorite question is coming to your screen. 60-year-old diabetic patient comes to OPD with extremely painful lesion in the external ear, and there was evidence of granulation tissue in the ear with facial nerve involvement. Fine. What is the most likely diagnosis? What is the most likely diagnosis? Answer this. Fatafat. This is a very nice question, and I'll again give you a fine methodology to remember. What is the answer? Answer to this question. Answer to this question. I shouldn't wait. Diabetes and ear. Answer is done. Remember this. Answer to this particular question. Yes. Fine. Remember some of the important lines that you should remember. And the topic is this particular thing. Diabetes in ENT. Just look for your gondoled words. Do not waste time in such sort of questions. Hamesha remember, whenever you see diabetes word and they are talking about ear, it is always malignant otitis externa. Diabetes and ear together, it is malignant otitis externa. No need to read the question completely. Diabetes and ear together, it is simply malignant otitis externa. Why to waste my time? I know you know that it is caused by Pseudomonas aeruginosa. Remember that. Pseudomonas aeruginosa. Diabetes and ear together, it is simply malignant otitis externa, also called as, they can change the word, osteomyelitis of skull base. Osteomyelitis of skull base. Such sort of word can also be used, osteomyelitis of skull base. Remember. Secondly, diabetes and nose together. Diabetes and nose together, 110% bachche, it will be mucormycosis. If in the question there is diabetes and nose together, it is mucormycosis. And still I am telling you, the question that they'll ask is that how do you manage mucormycosis? The drug is amphotericin B, particularly liposomal amphotericin B. Do not waste time. Just solve the questions in 5-10 seconds of ENT. Move forward. That was the methodology that I am teaching you in this particular session. Diabetes, ear together, malignant otitis externa. Acha, diabetes, ear, malignant otitis externa. Next question. Diabetes, nose, mucormycosis. Liposomal amphotericin B. My job is done. And diabetes, and if they are talking about oral cavity or neck, there can be only two answers. One is Ludwig's angina or Ludwig's abscess or parapharyngeal abscess. I'll tell you how and when you should mark Ludwig's angina or parapharyngeal abscess. If in the question they say that there is a neck swelling here, particularly in the mentum region, there is poor oral hygiene, diabetes word is mentioned, then mark Ludwig's abscess or Ludwig's angina. Please, if they specifically add one line that there was a lateral neck swelling, mark parapharyngeal abscess. I am telling you, diabetes and neck is Ludwig's angina. But if in that question they specifically say that there is a lateral neck swelling also, then mark parapharyngeal abscess. My friend, you won't mark it incorrectly. Remember that. Diabetes and neck or oral cavity, if they talk about it, is Ludwig's angina. But if in that question they specifically mention that there is a lateral neck swelling also, go for parapharyngeal abscess. Fine. Yes, you are rightly answering. Dental infection and dental caries are the risk factors. I am telling again, Ludwig's angina will come only with a submental swelling, trismus, mouth cannot be opened. But parapharyngeal abscess, there will be a lateral neck swelling also. Remember, my friend, they will specifically say there is a lateral neck swelling in case of a parapharyngeal abscess. That's why it is called as parapharyngeal abscess. Para, fine, lateral neck swelling. This is an image of mucormycosis that you can see. Fine. These are the two images particularly that they use for Ludwig's angina. Yes. Ankita Sharma, you are very rightly saying Ludwig's angina and parapharyngeal abscess, almost all the clinical features will be same. Remember, but if they specifically add a word that there is a lateral neck swelling, mark parapharyngeal abscess. I hope you got that particular point. With that, let us enter into the next question, my friend. And the question is, all of the following statements are correct for this particular disease, except see this tympanic membrane and identify the disease. First identify the disease and you'll get your question correct. You'll get your questions correct. Just identify the disease. All of the following statements are correct regarding the disease related to the given image of tympanic membrane. Identify the disease seeing that tympanic membrane. Yes. Identify the disease seeing that tympanic membrane. What is this condition? And what is the answer? What is the condition and what is the answer? What is the condition and what is the answer? Yes, perfectly, you people are answering it very much fine, very much correctly. It is a case of tubercular otitis media. It is a case of tubercular otitis media. And how I remember tubercular otitis media? I remember it by a mnemonic P, 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 P. There are multiple P's. First P stands for that it is pale, pale looking. Pale looking. Can you see it is pale looking? Fine. Secondly, next P stands for perforations. Perforations. There are multiple perforation. Can you see? Multiple perforation. In fact, if they give you multiple perforations, mark directly tubercular otitis media. If they show you multiple perforation in tympanic membrane, directly mark tubercular otitis media. Do not look for any other option. Third P, it presents with profuse ear discharge. It presents with profuse ear discharge. Remember it. It presents with profuse ear discharge. And last P, what is the last P? It is painless. There is no pain in tubercular otitis media. It is painless. And what is the treatment? It is anti-tubercular treatment. It is anti-tubercular treatment. It is not painful. So D is the answer that you have to mark. I hope you got this particular thing, you got this particular point. With that, let us enter into the next question. It is a direct question. You have to memorize these incisions. I'll write one by one. Remember these incisions. First, identify what is this given incision. One of the most commonly asked incision in all examination platforms is this incision. What is this incision? What is the given incision? Identify the given incision. Many of you are rightly answering this, perfectly answering it, and some are, wrongly answering it. Please remember, bache, the incisions are very, very important, and this particular incision is, please remember, Weil's incision, bache, post-auricular incision. Is Weil's incision, bache. This is the post-auricular incision, Wild's incision. Thank you so much, Paras, for this nice set of questions. I have not, used most common questions, particularly special questions, so that you remember some very important things. Post-auricular incision is Wild's incision, and this is the image. But for the people who are answering Kocher's incision, but Kocher's incision is for thyroidectomy. It's done for thyroid. This is ear, bache. Kocher's incision is done for thyroidectomy. No need to feel sad, my friend. Mahib, no need to feel sad. In fact, it is not at all required. You are not sitting in your examination hall, bache. You are getting things. You are definitely getting things. Fine. Kocher's incision is done for thyroidectomy. It is Wild's incision. Post-auricular incision, that is the Wild's incision, and the other incisions that you have to remember. Can you see this image? This image is basically, bache, remember, Rosen's incision. Very important. All these incisions are very important. And lastly, this is your Lempert incision. Lempert's incision. Lempert incision. Lempert incision. No need to worry. These incisions you have to remember. Kocher's is for thyroidectomy, bache. Fine. Then you have to remember these 3 ear incisions. This post-auricular is the Wild's incision. Fine. Then this is the Rosen's incision. And lastly, the Lempert's incision. All of these are mostly done from CSOM diseases for the treatment, like we do tympanoplasty and mastoid surgeries. You people are very rightly answering it. Fine. Coming to the next question. C type of tympanogram is seen in. C type of tympanogram is seen in. Come on, come on, come on. C type of tympanogram is seen in. C type of tympanogram is seen in. Answer this, and I'll come to this part. I'll come to this part. You directly have to identify these tympanograms. Graphs will be given, and you just have to identify. See, you can see type A. Then you can see type AD. You can see AS, B and C. Fantastic. People are answering it. C type of tympanogram is a feature of Eustachian tube dysfunction. Eustachian tube dysfunction. C type of tympanogram is seen in Eustachian tube dysfunction. Let us, revise and memorize it together. Type A is basically normal. Remember, type A is basically normal. Type AD. D stands for, let me ask you, D stands for? Today I'll, open your horses. I know what you'll answer. I know what you'll answer. I'm waiting. What this does D stands for? What does this D stands for? What does this D stands for? This D stands for. Bache, I'll tell you something important. This D actually does not stand for dislocation. Because you want to create a mnemonic dislocation disruption, you label it as dislocation disruption. This D actually stands for deep. The graph is deep. D stands for deep, and and the mnemonic that you remember is dislocation of ossicles. Fine. You'll be amazed to know this thing today. This D actually does not stand for dislocation. This D stands for deep. The graph is deep. And similarly, fine, opposite of deep is shallow. Opposite of deep is shallow. So this S stands actually for shallow, and you remember it as otosclerosis. It is seen in otosclerosis. Remember, my friend, I know that you know the examples, but remember D and S. Fine. Similarly, this type B is seen, which is a flat curve. Type B is a flat curve, is seen in glue ear. And lastly, type C is seen in Eustachian tube dysfunction. Eustachian tube dysfunction. Eustachian tube dysfunction. Eustachian tube dysfunction. Today, my sole motive was to open your horses, to open your brains. Fine. The question is, patient presents, easy question, very easy, small topic. I'll hardly take 5 minutes for this. Patient presents with pulsatile tinnitus and decreased hearing since 4 months. On examination, it was found as a reddish mass behind intact tympanic membrane. All the signs are seen in this disease except first identify the disease. If you have identified this disease, well and good. Remember always, a reddish mass a reddish mass behind an intact tympanic membrane always gives a diagnosis of, remember, glomus tumor. Fantastic, people are answering glomus tumor. A reddish mass behind an intact tympanic membrane. You have to actually identify the disease. Yes, you have to identify the disease, and this disease is, I'll just remove this line. What is this disease? Disease is glomus tumor. Remember, what is this particular disease? This particular disease is glomus tumor. Remember, my friend, this is glomus tumor. What is this particular disease? And in fact, I always say a reddish mass behind an intact tympanic membrane is glomus tumor. Which side tympanic membrane is this, if anyone can answer? 5 o'clock position, right side tympanic membrane is this. Fine. And the very important signs that you have to remember for glomus tumor are these particular things. Don't worry, bache, I'll explain little bit of otosclerosis and Meniere's disease. Don't worry, relax. Fine. The signs that you have to remember for glomus tumor. In fact, the main thing that you have to remember for glomus tumor is the image. Firstly, a reddish mass behind intact tympanic membrane, pulsatile tinnitus, and the signs. You just have to memorize these signs. First is the rising sun sign. Remember, rising sun sign, that means tumor is coming from below. Secondly, brown sign. What is brown sign? It is a blanching seen on pressing the tympanic membrane. All these 4 signs are very important, my friend. Equinus sign, it is a blanching seen on pressing the ipsilateral neck vessel. And lastly, the normal partition between carotid and jugular are lost in this particular tumor. This is called as Phelps sign. If you know all these 4 signs, well and good. I have a gut feeling very highly important are these particular 4 signs for glomus tumor. This you have to memorize. With that, let us enter into the next question, diagnosis. Diagnosis, please. Think about it, then tell me the diagnosis. A 47-year-old chronic smoker fruit seller came to ENT OPD with chief complaint of change in voice. Endoscopic examination reveals the given image. What is your diagnosis? Think about it. Do not be in that hurry. Think about it. See the image and then answer. Think about it. See the image and then answer. Fantastic, fantastic. Congratulations. My best wishes. It is vocal polyp. It is vocal polyp. It is vocal polyp, not a vocal nodule. It is a vocal polyp. Unilateral, bache. Vocal polyp is unilateral. It is unilateral. It is vocal polyp. This is vocal nodule. Nodule is always bilateral. And I want to tell you one very important thing that you should remember. In nodule, the causes or the risk factors are voice abuse and acidity, laryngopharyngeal reflux or GERD. Laryngopharyngeal reflux, laryngopharyngeal reflux and voice abuse are the risk factor, not smoking. Smoking is a risk factor in vocal polyp. Remember, my friend, remember this. In vocal polyp, smoking is a risk factor. I specifically mentioned smoker. Smoking is a risk factor in polyp. But here in nodule, there are 2 risk factors that you should remember: voice abuse and laryngopharyngeal reflux, acidity. Fine. It is always and always bilateral. Polyp is always unilateral. And lastly, remember one more disease, that is ring case edema. What is ring case edema? In ring case edema, yes, fantastic, you people are answering it very correctly. It is seen in teachers, screamers, yes. Particularly, profession like me can land up into vocal nodule. Fine. Talking about ring case edema, what is ring case edema? It is collection of fluid in subepithelial space. Collection of fluid in subepithelial spaces of vocal cord is ring case edema. Collection of fluid in the subepithelial spaces of vocal cord is ring case edema. Such sort of image will be given in case of ring case edema. Again, the risk factor is smoking and voice abuse. Remember my friend. Remember, you should remember, you all should remember. All these three important conditions, vocal nodule. Nodule is bilateral. First of all, remember, teacher, screamer, they will say, or fruit seller, they will say, but they won't use smoker. Smoker, they will use in case particularly of polyp. Polyp is unilateral. And lastly, ring case edema is a different sort of image. You cannot make a mistake. Nodule, you will do voice rest, and polyp, you will do stripping, MLS, microlaryngeal surgeries. Fine. Very important repeated question that I am telling it to you. You should remember this next question. A 6-year-old child was operated for chronic tonsillitis, had undergone tonsillectomy. 4 hours later, child started having bleeding from mouth. Examination revealed, in fact, such sort of question was there in your recent FMG examination. Only the hours were different. Let us see this question. A 6-year-old child was operated for chronic tonsillitis and had undergone tonsillectomy. 4 hours later, child started having bleeding from mouth. Examination revealed bleeding from the tonsillar side. What shall be the management of the patient? What shall be the treatment? Answer it. Answer it. Such sort of question, yes, in ring case edema also will preferably do, that sort of stripping that will remove the fluid. Fine. Answer this. Yes, perfectly fine. People are answering it very much correctly. The option number is option number C. In tonsillectomy, you have to remember that there is something very important complication you have to remember, that is the hemorrhage, bleeding. It is classified into primary hemorrhage, reactionary hemorrhage, and secondary hemorrhage. Primary hemorrhage basically happens at the OT table itself. Primary hemorrhage happens at the OT table itself. And what is the most common vessel that bleeds in case of tonsillectomy? Remember, it is paratonsillar vein. Do not make a mistake, my friend. Secondly, reactionary hemorrhage happens within 24 hours. Reactionary hemorrhage happens within 24 hours, and in this question also I had given 4 hours. It happens within 24 hours. Why does this happen? It happens because of slippage of sutures. Slippage of sutures. Slippage of sutures. And how will I manage it? I will do immediate surgery, that is immediate exploration, surgical exploration I'll do. Surgical exploration I will do in this case. And lastly, there is secondary hemorrhage, and the secondary hemorrhage question was asked in this FMG examination. They had given 7 to 10 days. After 7 to 10 days, child started having bleeding from mouth. It happens because of infections. And how will you manage it? Infections obviously will be managed via antibiotics and IV fluids. I'll prefer IV antibiotics and fluids. I hope you got this particular thing, and with that I come with the last funny sort of a image and funny sort of a question. This is your last 25th question, my friend, my comrades, my doctors. Identify the disease associated with this sign. Just an easy question for an easy life. A 28 years old female comes to ENT OPD with bilateral decreased hearing. Dr. Saab, what has happened to me? Ma'am, you are suffering from one MCQ. What is the MCQ I am suffering from? Ma'am, you are suffering from this particular thing that gives a flamingo pink appearance, also called as Schwartz sign. Sir, how will you manage this particular case? Ma'am, you are those specific cases that I particularly like, because I will do surgery, ma'am. And the disease that I am talking about is none other than otosclerosis. Fantastically, you people answered. And at last, for otosclerosis, I want to tell you one thing. You will enjoy this line forever. I always say, otosclerosis is seen in females. It is bilateral decreased hearing. Fine. S stands for here in otosclerosis. Here S stands for Schwartz sign. Schwartz sign is seen in otosclerosis. Again, S stands for surgery is the treatment of choice. Again, S stands for what is the surgery? It is again starting from S, that is stapedotomy and stapedectomy. And again S, that there is a S type of tympanogram. Tympanogram, my friend, a S type of tympanogram. With that, I always say, my friend, remember this for life. If you won't clear it, someone else will. Let us together choose someone's side. There are number of people, number of faculties, number of friends that are praying for you, that are, wishing or hoping for you. I won't do that. I won't do that. I remember my days. I will just wait for you. I will just wait for your results. I will just wait for this happiness that we together can share. I will just wait for the day that you share that happy news so that we can together celebrate. My best wishes to you all. For any doubts, this is my Instagram ID. You can anytime, contact me. There has not been, God allows me the same, not even a single day within the 24 hours, I have not replied to a child. It does not happen. I will surely reply. But again, I'll wait for you. I'll wait for you. With that, thank you so much. Namaste. Spasiba to all my friends. Madluba to my friends. These are the foreign languages that I heard. And once again, Jai Hind.